House Healthcare on January 23rd. And we have with us next on BAA, Diva. So welcome, and you can come up to. And maybe since this is the first time that we've had you in the room and first time I think you've ever been in this room in your relatively new role. Your relatively new role. We should probably go around the room and just do quick introductions of who we are and start with Lori.
Lori Houghton, Essex Texas. Introduction.
Oh,
Very sorry, I apologize. Melissa Goldman from Bells Falls area.
Debbie Flowers, Waterford.
Chocolate McFarland, represent Barrytown and Williamstown.
Alyssa Black, and I represent Essex.
Daisy Rebecca, I represent Williams.
Andy Critchlow, I represent Colchester.
Page Newport.
Alan Dwyer, Enosburg, Montgomery.
Good morning, I am Sean Rose. I am the DEVA Commissioner. Just joined 4 months ago. I brought with me Stephanie Bartlett, who will be walking through the BA with you all today.
I am Stephanie Barrett, the Financial Director at DEVA.
Great. And you've been here longer than 4.
Yes.
And I think we have on our committee webpage for members of the committee, if you want, we have Diva's budget requests, but also their narrative, which I always really love the narratives. So thank you for that.
So, would you like me to just?
Yeah.
We do present the budget in the narrative form and what's called the ups and downs, which are the incremental changes from the budget that you passed in the spring. That are the current fiscal year, the midstream adjustments to come into alignment fiscally. And is the committee's pleasure to sort of walk through the narrative that the easier, we can switch to the ups downs if we need to on detail when you want to go granular.
I think that you should present in whatever way you feel best
Okay.
prepared to present,
Okay.
and we
So-
can modulate to that.
Okay, so I'm going to work off the narrative document, which you have in your screens or on pieces of paper in front of you. And so the first appropriation, DEVA has 4 budget lines in the budget every year that are base budget lines. And the first appropriation is our administration. The whole administration of the department is in one budget line. And so you can see on the narrative, it costs $179 million to run DEVA, is the estimate after budget adjustment. Most of the adjustments in the administration line are technical adjustments. The first one in item 1 in our staffing and contract area is not a technical adjustment. It is having some temps on board to help us clear the backlog of our aged, blinded, disabled population in the redetermination. We have a backlog of in the vicinity of 1,500 still. We have a deadline that we have to meet by the end of December. The folks in this category are not likely to go off Medicaid. They're likely to be continuously eligible, but they're ones we couldn't get done in the main unwinding of last year. And so that is one item, the first item in our admin budget, that $331,000 gross expenditure that we're having that we didn't anticipate when we built the budget last year. The next item is legal aid. This is the same, this is not a new item. We're just putting it in the right position in our budget. It had been carried down in the program budget. It needs to be in our administration budget.
So this is just a transfer?
This is just a technical, put it in the right spot. And then we have a few adjustments to some DEVA contracts. One is an amendment to our NMIS contract. We have the Justice Reentry Initiative that needs to have some contractual help to get off the ground in DEVA included in our system. And then we have some technical adjustments that are net zero, but the funding items are moving around in our DEVA health contracts.
Is that the correction you mentioned, is that the new waiver is that what you're referring to? Because didn't we get a waiver for?
We've got, we got a new waiver. The justice reentry was approved, I think, in the previous waiver amendment. But it's the fruition of that project is moving forward.
Different than that. Did you have a question, Basil?
No, I was just shaking my head.
Okay.
But it's similar to it. The new waiver amendment we just got, this was one I think we got a year or 9 months ago. I have to check with Ashley on the timing, but, and then in our operating budget, most of it, Viva pays for a lot of development, IT development, but the contracts themselves are held in ADS. And so we are making technical adjustments to lots of things that are held in ADS, either a contract or what's called their service level agreements, which is how ADS bills back to the service they provide the departments. And so that is what you're seeing for the most part in our operating expense. But we are having one item, if you're on the ups and downs, that is a $200,000 general fund item, a $2 million gross item. We have to go out to procure a new pharmacy benefit management system. And so this is the initial steps of technical help to start that process. So that's that you see, if you're in the ups and downs, it's the very last item in our admin budget.
So we are getting a new system?
Yeah.
We have to, we're starting the procurement process. It's a multi-year process, but this is technical assistance to start that procurement process.
Okay. Did you have a question, Leslie?
I'm not sure if I should remember this, but why is this happening now?
What usually drives the procurement is the timing. We have to go out to procure when a contract, you can't just extend after you hit a certain amount of time. And
So it's the end of the current contract and now you're.
that's how, yes.
Whenever that is.
Yeah. What we see with the end of the current series of amendments that we have for the current provision of service, we have to prepare for a procurement process to meet that timing.
So meaning putting it out to bid and that you.
Well, developing the RFP
Yeah,
first,
yeah, yeah. Yeah.
getting everything,
Yeah,
um,
but it could be the same person, the same organization in the end.
it could be,
Yeah.
it could be. But it, that is good practice to go through that
For
process.
sure.
But we received $8 million in federal funds.
Oh, no, that's a purely technical, sorry, I didn't touch on that one.
Yeah.
That is just purely internal. That is a holdover of an overstatement. So an appropriation is a spending authority limit. And several years ago, the federal fund line in our admin budget was increased for an IT project, but it got embedded in our base budget. It should have been with the one-time general fund. And so this is just right sizing that spending authority line. It's not good to have too much spending authority. And then federal funds we get a spending authority of federal funds, but that we have to earn the federal funds. We have to actually demonstrate that we spent the federal funds on the, eligible expenditure, and then we draw them in at the right match rate. And this is simply technically leveling our federal fund to the right position in our overall admin budget. It doesn't act any particular project. It is a purely technical correction.
Okay, great, thank you.
So that's the story of our admin. Yeah.
Sorry, Lori.
That's a good question.
Sure.
On the, needing to go out to procurement every time a contract ends again.
Well, you can, not every time a contract, you extend a contract for a given period of time. And then when you hit the limit of how many times you've done that, then you do. And then there are federal requirements on how often you have to re-procure.
Okay, so the
things.
federal requirement.
I think this is our state requirement that we've hit the
Okay.
limit on how far we can extend.
Okay.
Yeah.
So, okay, that's great. I'll
Yeah.
ask some questions offline. Thanks.
Okay. So now we're going to move to our program budget, which is a little over $1 billion in a scheme of things, state budget. And we have a very large adjustment that we're asking for mid-year. And this is one committee that has several members that were on last year. And
Dave, would you prefer to? And this, you're welcome to sit here at the table. Oh, I'm sorry, actually, apparently Brian is on the way, but we have a seat over here if you'd like. Okay. Oh, yes, and just for introduction, Representative Iacovoni, from House Appropriations, and you know, he looks at your budget.
yes, he does. So the first adjustment in our program budget is $83.5 million in all funds across all 3 program lines. And that's a sizable increase. What is driving that is we, you probably, most of you know, the process of the baseline budget in is a consensus process, and it has been for, you know, I think since 2008, 2007, going on 20 years. And that is DEVA, the Central Office of the Agency of Human Services, Finance and Management, and JFO. We look at the caseload, and then we look at the cost per case based on the, experience as up to date as we can see that. And then we, adjust for things that are new, like if you ask something that, adjusts our prices or add something or take something out, we make those adjustments as we forecast. And when we forecast and were in front of you last year on the 25 base budget, the indication was that we would be asking you to reduce our budget. We were basing that on 4 quarters of data that didn't have the full impact of the redetermination in that. And so for those of you who follow sort of what we put out monthly on our dashboard, we started to see that that wasn't correct toward the end of last fiscal year. And March and April and May, we saw that we were out of sync with the 24 budget, and we knew that that was going to lead to being out of sync with the 25 budget. And so through the fall, we had more up-to-date actual experience in the new redetermined caseload for us. So the caseload projections stayed consistent with our expectations. It's the cost per case for the folks that are in our caseload that we got wrong last year. And that's what is reflected here in this ask.
So if I can, I'm just trying to understand. So essentially, your prediction of eligible after redeterminations was correct.
Yeah, the count of people was.
But those people their costs are more than what you had anticipated.
They are, and what we essentially got wrong is how much the remaining folks in our caseload had as a share of the cost previously versus the folks that were churning out as a part of redetermination. That's what we weren't able to see as clearly last year when we first built this. We thought that the differential between those two groups was smaller than it was.
Okay.
Turned out to be.
Is their utilization up? Are they utilizing more services than previous, or?
So what we've done analysis to see on the 4 major categories, particularly looking at the folks that remain in Medicaid versus the folks that left over time. So in inpatient, outpatient, pharmacy, and professional services, we focused on those particularly in the fall. So we didn't have the full 24 picture. But what you could see in that is, first of all, you can see the difference between the folks that came off the program were lower utilizers than the folks that stayed on the program, which is to be expected, but that differential we didn't get right. And then the other thing we could see in that is you could see the utilization had come up through 23, that we probably didn't pick up that enough last year when we were, a year lag of time there. And then the sort of slightly good news we hope is that looks like it's leveling. The trend up is not continuing to go up at that rate. It seems to be leveling.
So the 4 service areas that you identified.
Yeah, so just to try
Trends
to
on
understand
it.
stuff, we did look at volume too, and it's not, we don't see an increase in the volume of the number of claims per person.
Okay,
But the actual expenditure for the folks that we have enrolled, we do see that through 22 and 23, that was a rising cost per case, that we didn't fully capture when we built the budget last year.
are we seeing, I guess what I'm asking is, are we seeing trends in, say, prescriptions are rising higher than other, inpatient or outpatient or professional services that you said you identified
So
for areas?
So we look at, this is a fiscal picture,
Okay.
and so we're not getting as granular as, either by hospital or by, we can see that the pharmacy that we're projecting is very similar to last year, but it's on a smaller base of people. So that is a higher cost per person.
Okay,
But the base of people last year was, with a partial year of unwind, it still had the inflated number of count of people in it. So,
are we done with unwinding? Just,
Yeah.
and I'm gonna let.
so we are, with the exception of the temps I talked about in that backlog.
Okay.
And so we're in the regular cycle now where we're redetermining everyone on their yearly cycle.
Great, Mari?
Does this include the 6-month period of time when there was a cyber attack and there were prior authorizations of really expensive medications? Is that another reason that is higher than you expected?
The cost of pharmacy, that is an issue that we are trying to sort of identify. Can we fully quantify that issue? It is embedded in this in terms of the size of that in the overall Medicaid budget. That's not going to be enormously significant, but the actual expenditure of those drugs that have come through are embedded in to the extent that there's always a lag on claims. The service is provided and then it's 6 to 8 weeks or even a little bit longer before the actual claim shows up. And this is the cash-based budget, so we are always, looking at what we've actually expended the state. We're not like a insurance company that is, looking at the accrued pieces we're trying to do that when we build the next budget, but that is included in here, as well as the impact of what we're seeing on pharmacy rebates.
It's a great point, and we should probably know, because I don't think any of us are, what problem was identified due to the cyber attack, other than.
So when it was at the end of February last year, we had the Change Healthcare cyber attack where that whole system, which is our pharmacy benefit management system, shut down. We continue to make payments to pharmacy on behalf of Medicaid patients based on their past experience, and then we trued up, and that was very successful. And we also did that for other providers who were impacted by Change because they couldn't get their claims in, because Change was a clearinghouse for other providers as well. But in that process, the functionality of our pharmacy system didn't really come back and isn't even now fully back. But in that process, we weren't able to do real-time prior authorizations. So we did have some scripts that were filled for things that, if the system was functioning, would have been directed to an alternative. And so that hasn't had an impact on us.
Do we have any sort of recourse
We are,
to change? I mean, do they need to, can we fine them anything, or, I mean?
so we have under our contract provisions,
Uh-huh.
and that's an internal discussion that's going on right now.
Any questions around increased utilization or just vote? Right,
So that brings our base budget up to our best current estimate of what it needs to be, essentially. And then the second item in our budget adjustment, and these may be familiar, but we have a couple items that sort of every January tick on the budget. We have the indexing for the payments to the federally qualified health centers, the rural health centers. And it's a partial year, mid-year adjustment, so we don't know what that basically that index, that inflationary bump will be. We estimate it. And then you'll see this again when we present our big budget, in a couple weeks, fully annualized, but that's the majority of this. And then we also have to keep, a floor, a rate for our hospice services. So that comes up at the beginning of the calendar year as well. So that's what's in item number 2 is a rate increases that we keep up with. Item number 3 is back to change healthcare. But it's in the good direction. It's an actual reduction in cost, but it was in addition to what we just talked about, the functionality of the pharmacy benefit system. In Medicaid, the pharmacy services, the drugs that we pay for, also come with rebates. We have mandatory rebates under Medicaid, and then we have supplemental rebates for drugs. And that system is a system where the pharmacy benefit manager provides that service to us of tallying up what the rebate billing to the manufacturer should be. That got disrupted last spring as part of the outage. And so the rebates that we were expecting to come in our state fiscal year 24 by the end of June, we could tell were not going to come in because they weren't going to get billed out in time to come in. And so that meant that we, as a department, had a gap in closing our fiscal year. And that was the agency covered that, helped us cover that to close the fiscal year properly. But it also meant that the rebates that we thought would be coming in April, May, and June were coming in July and August and September. And so they have come in and so they're available to help offset our budget right now. So this is a negative that helps offset that $80 million. But it's one time, it's just the timing gap of the rebates. And number 4 is the ACO reconciliation for the 2023 calendar year, service year under the ACO. And the good news in this one is, even though it is $5.1 million, the portion of this reconciliation that is tied to the total cost of care was very, very close to being what was projected. In fact, there was a tiny amount of money, just under $500,000 that the ACO would have owed us under that portion of the reconciliation. Unfortunately, the unwind and the public health emergency that kept people on for so long, we have a second year with we had a similar experience last year. The portion of the reconciliation where the eligible folks that attributed lives to the ACO were paid based on, for example, a child, if they aged into an adult, we were paying them in 2023 based on that life being under 18 years old, even though they might have turned 19 or 22 years ago because we weren't doing the redeterminations. And so that's all being caught up in each year, that the right life is attributed to the right category. And so children are we make a lower payment for a child than we do for an adult, and a lower payment for a general adult than we would for a disabled adult. And so the portion that is the lion's share of this reconciliation is due to those true ups of it's an artifact of the long 3-year no redetermination through 23. There's always a little bit of that in a normal year, but and so next year when we reconcile 24, it should be a much, much smaller, just a year's recategorization of, somebody that actually moved from 18 to 19 in 2024 versus, somebody that was 2 years out of whack in the program.
Okay,
Gorgeous.
Sorry.
I'm curious about the pediatric population and why, and on what basis were they reimbursed at a lower rate? Is it actuarial data? Is it actual
Yes.
medical data that shows their lower acuity, which that wouldn't make sense to me?
So the rates that we pay to the ACO are, there is actuarial analysis of that every year. And we have an actuary and the ACO has an actuary and we come to agreement. So both sides are having their actuaries look at the past experience and updating the rates that we pay for the populations that are, in the ACO's case, the attributed population.
It's strictly actuarial.
It is, and then it's trued up to actual experience. But we see that too in our, just our general population of children is lower cost per case, a per member per month cost, compared to our general adult population, but. Yeah.
Leslie, did you have a question? Sorry, I didn't know if your hand was up.
Not yet, but I have a question.
Okay.
Maybe at the end.
Let it percolate for a little bit.
We have a couple of just neutral technical adjustments in our program budget. One we've already talked about, that's the legal aid piece moving out of program and up into admin. And then we have two programs, our Blueprint Spoke program and the Pregnancy Intention program, which used to be called the Women's Health Services program. Those were in our base program budget, but they need to move to and be categorized as a waiver investment. So there's no change in the cost, there's no change in the match rate. It's just where we have to account for them. And so we just have to move the pieces of those programs into the right line item. So they're net zero impact to the budget. And then the last item in our base budget before we get to one times is an adjustment downward of the Vermont cost sharing program for 2025 plan year. And that is related to the pricing of the silver plans. So the cost sharing program is tied to the silver plan. And so we have far less people that have opted for the silver plan, intentionally designed that way. And so the cost of that program is going down. And you'll see this again when our budget is, our full year budget is presented as well. And then nothing changes with the premium assistance. It's just there is less need to provide this service if people are choosing higher metal plans. And that's, I know you've heard about that from Addie and others. So that's the picture of our base budget. That encapsulates everything that's on our ups and downs for DIVA. And then we have two items in our one-time section. So last year we asked for one-time money for the global payment pilot program, and 5 hospitals entered into that in the summer. And this is adjusting that. This payment is not, this is just to cover fiscally the timing of that. That's moving the remainder of the items that Medicaid pays for the non-attributed lives. So it's the same set of services that go through the ACO. For the attributed lives, this was paying so that, between the two, you get a global payment for all that basket of services that flow through the ACO. This adjustment is allowing other hospitals, the first 5 that opted in, other hospitals to opt in and to true up the estimate for those first 5 hospitals, because it was the UVM network hospitals, Rutland, and another hospital. So that ended up slightly higher as a fiscal tail impact to us.
Is that Brattleboro? What's in Brattleboro?
I think Brattleboro is one of the ones that's interested potentially coming in. I think it's St. Johnsbury that it's in.
Yeah.
So it's a one-time bridge the fiscal gap between, we're gonna pay you prospectively, but you're gonna still have a rollout of claims that we have to pay you for too.
Is everybody? Great.
And then the last item, which was new to us last Friday, is a $10 million general fund line item for provider stabilization. And that is going to be, done on a case-by-case basis. The central office is supplying some technical assistance in the form of, accounting assistance, so that providers in stress can come and we can evaluate if having a grant would lead to a stable, and, it's a challenging one to administer, I think. But
Go ahead. No, go ahead.
So I know we've done this in the past, and so are we using the same program mechanism so we can get it up and running quickly? Or is it a whole new thing you have to set up?
so we're using pretty much the same mechanism. It's just going to be in Diva as opposed to in the central office. And this technical assistance through a contract in the central office is going to be helpful. It is challenging. It's a fixed pot of one-time money. Timing is, what it will be.
Yeah.
When is the last time that we did this? Did we do one last year? Or was it the year before?
You did have funds in, I think the funds went in 2 or 3 years ago. I know, I'm aware of several that came through Diva to look at. And then you also sort of swept out the balance of that previous fund as part of the budget bill last year.
Okay, so not all those funds were used.
Well, they weren't used for that purpose, but they were pulled back.
What was left over was swept up. Do you have any recollection of what was?
I have to go check what that amount was. It's actually probably stated in the budget bill somewhere, in the one-time section.
Right, and I'm assuming since you're asking for this in budget adjustment, that you're anticipating the need for this.
So, just to be, this was sort of under discussion. It wasn't in our initial present, when we were in House Appropriations a week ago, this item wasn't on our list yet. So it was new to us on Friday. It does incorporate $4 million that was in the original budget adjustment proposal in the health department for SUD specific providers. That's been subsumed into this 10 million being lodged in Diva now. And so I suspect that there are, SUD providers that we will be working with the health department to address through this pot of money.
Daisy, did you?
Can you speak more broadly as to the types of providers that this may benefit? And also if it's really about stabilization, I'm concerned that unless this is all going to one organization, how much can it really stabilize an organization that's in a fiscal crisis?
I don't have an answer to that yet. I mean, this case by case, it would be met, if there's a financial backlog that this can offset that actually fits into the stabilization plan that the organization has, that I can see, if you have a long arrearage with vendors, and this brings you up to, and everything else about your plan is solid, and your marketplace is solid, that you know, it has a good probability of being viable if you can alleviate some one-time liability. That's I would think the main way that this would work.
So would we, I wasn't familiar with the previous programs, so for those of us who aren't at least recalling it, is there sort of an RFP that outlines what the qualifications for the grant awardees might be?
So it's we can get you what was previously used for the financial information that we ask about and the planning that we ask about. The new piece would be this third party that would help us vet those that I wasn't quite as it wasn't in place for the previous version.
Yeah, I'm just curious because I know so many of our organizations are in financial crisis and are going to be interested, and I could just see what if, how are you going to weed them all out? Right? Everybody needs this money.
If I could just follow up, I don't know if you have any examples of what the last provider stabilization money was used for, just so you can give us an idea of what it's used for. And then I have kind of a follow-up to that.
So I know that it was used for when the Franklin County Home Health Agency was transitioning and basically, winding out of business in its current, in the form it was, and helping the next agency that was willing to step in and take that on, helping them bridge that. That was one example of how it was used. I know it was used for a couple specific FQHCs. The details were, sort of predated when I started at DEVA. I know that there were some asks that were no in the past. But that's
I'm also.
that is part of the challenge of it.
I think the home health is a great example.
Yeah.
I think what I'm thinking about is 10 million in BAA, which means that and you did mention like 4 million substance use that you think it might, some of that go to, but that you're asking for 10 million right now. And we've heard from an awful lot of organizations. I'm wondering if you think that 10 million is enough.
I don't think we're the ones to answer the question. I mean, it's one-time money and it's case by case and it will have a finite life.
Do you anticipate that you'll be asking for another one time in the budget?
I don't.
Can't say yet.
Yeah.
Okay. All right, well, we'll wait. Stay tuned. Mari, did you have a question?
I think Leslie had one before me. Do you still have it? Well, I want to go to, when you're done, to your spreadsheet. My question's gonna come to that.
Okay, sure.
I'm just trying to get more clarity around what providers you're talking about. I know you mentioned home health, does this also include independent, like primary care providers?
Yeah, there is a number of FQHCs and practices that have come forward, saying that they need some sort of grant funding from the agency to help them make payroll or bridge that gap.
Thank you.
Any other, Woody?
It looks as though you have an idea where some of these funds will be going already.
We've been approached. Part of that is, Stephanie has said is that we will be using the accounting firm from central office to kind of help vet that process.
And do you expect to use all the funds?
We don't know. I mean, we've only heard from a number of providers thus far, and this is not something that we have put out there. But we don't know who else would approach us.
And how difficult is it to apply for a grant and receive one? With your criteria, I mean, I'm assuming it's a lengthy process. It's not an easy thing to probably get in.
I don't know if I can handicap that for you. It's it is a lot of financial reporting. It is a lot of understanding the strategic plan and what that means.
Okay, thank you.
Just a quick question, are you ever thinking of reinstating the premiums that were suspended during COVID for some of these programs?
So that is not in the immediate future. And in fact, I think there was a slight change or words in the budget bill last year that, authorized that. So there's nothing contemplated that I'm aware of. That authority, I believe, still exists, but it's not.
Just wondering, I always wondered if it was cost effective either, because we're paying this vendor to send out premium statement.
That contract has ended.
Yes.
I think I'm gonna just ask one last question, if nobody else has a question. Leslie, did you have a?
I wanted to go to the spreadsheet when you were ready for that. I didn't know if you were ready for that.
I guess my thought is, are we identifying the areas that we seem to be using these stabilization grants for? And are you going to be recommending rate increases so that we don't have to do emergency stabilization for them in the future? I mean, it feels like a grant to stabilize someone, we're just plugging a hole individually. Are we looking at it as a system of whole and thinking about rate increases and rather than doing one by one? So that we don't have to have this program. I mean, and I think this is wonderful. But I wish we didn't have the need for that.
Yeah, I think it's something that DEVA and the central office is exploring of collecting of who comes into the program and what kind of policy and programs are needed to kind of make sure that this does not keep coming up again.
What do you?
Yeah, one more question regarding the grant related to the vendor. Is this something, the vendor, is this already on contract? How much do we actually pay for the vendor to process this $10 million?
Oh, they're not going to be processing. They're going to be a consultant on a case-by-case basis as we evaluate the applications that we get in. We will be processing the grants.
Okay.
This is, basically technical assistance on an ad hoc basis to help us.
So how much do we pay?
We'd have to get back to you on that. I don't know off the.
Would it exceed the 10 million that we're giving?
Oh.
I'm just curious.
It couldn't possibly, but I will get you the either the figure or the range.
Thank you.
Anyone else? Leslie?
So can we go to the spreadsheet? And I don't know if you want to get it up there or you want to look at it. I just want to understand sort of the whole ask as a whole.
So, the whole ask at the bottom of the spreadsheet in the sort of blue and white section. This is the base. It doesn't include the 10 million or the global payment tail piece. This is just the base items, the admin and the program budget. So if you go across total increases and decreases for FY25 budget, sort of right in the middle of that blue and white, it's a $3.25 million general fund up in our budget. In total, it is a $69.68 million up to our budget for spending. Of that amount, the portion that is 64.856 of global commitment funding, that has a general fund component. It's just not in our budget. It is in the central office budget. And so 42% of that 64 million is general fund. But what we are estimating to spend more than what we previously estimated when we presented the budget a year ago, is the $69.684 million flowing out of DEVA
But what you're asking for is an increase of 3 million from the general fund,
in our budget alone,
just for DEVA.
just for DEVA's general fund portion. But I just want you to be clear that the portion, the $64 million of global commitment has a general fund component. It just doesn't show up in our budget.
Okay, because there was the whole utilization increase, looking at 35 million. And I just want to understand, where is that in here?
So the $78 million that's in section 308. That's on the first page of the spreadsheet. On the spreadsheet,
Oh,
the
sorry.
very first line of the second appropriation. So it's after our administration budget. And then you see caseload and utilization and global
Are you in
commitment.
310 or 309?
I'm in 307.
Aha, that's why I'm having trouble. Appreciate that. Let's use numbers. Okay, go ahead.
So that first line, that's where you see the $78 million.
Yep,
The $33 million of general fund that goes with that,
Yep.
that you see on the narrative,
Mhm.
that you would see in the central office budget. We receive the 78, and they have the 33 and the federal funds that allow that 78 to be expended.
okay. So the 33 central office, which we heard yesterday from the secretary, so that's where that
Yeah.
would land?
That's where the structure of the global commitment waiver is, that the state funds and the federal funds to support anything that is a global commitment expenditure. The state and federal funds are appropriated in the central office, and those are matched together. And we spend the matched together dollar, and the Department of Health, when they spend a global commitment, or the mental health or DAO, when they spend a global commitment dollar, they live first as their state and federal components in the central office, and they're matched, and then we spend the matched dollar. That's why global commitment's always a duplication in the budget.
So the spreadsheet only looks at 4 sections, and there isn't a total of all 4 sections.
Oh, yes, sir. That's what's at the very bottom line of the
Oh,
one point two
those
five.
things that you were just
Yeah,
talking about,
yeah.
okay, that just didn't have a label, yeah.
Yeah.
So I just want to know, the general fund you're asking is 117 million? Am I getting that right?
That is the total budget of the total amount of dollars in our budget that we're asking for is 117. Last year we asked for 114 when we presented the budget.
Okay,
And we are asking for 3.25 more to get to the
compared to
117.
last year,
Yeah.
that's what you're saying.
Yeah.
Where does that money come from? 117 million, how does that work?
So that is general fund dollars.
So we need to add more money, but I'm just trying to understand.
So
that.
you've already granted us 114.
Right.
Of spending authority. That's accounted for in the budget. And the budget adjustment is asking for 3.2 more to get to 117.
3.2 is that,
3.256 is the budget adjustment of the general fund. It's this right there.
3.256. So you're asking for 3.256 million,
That's what this budget adjustment is asking. That's the incremental change.
which is pretty small, I guess, if we're looking at the whole. I'm just trying to
Yeah, but it's, general fund is always where you're
Yeah.
collectively.
So where does that money come from? The 3 million?
So it's part of the total, you had your emergency board meeting and your revenue forecast. The general fund has a revenue forecast and it pays, that's the source of funds for all the appropriations of general fund that the legislature grants to all the departments in the state.
Okay, thank you.
Any other questions before? All right. Well, thank you so much. Thanks for coming in.
Good luck, 'cause we-
Thank you.
Yeah.
Yes.
Um,
Advent.
Why don't we take a short, just like a 10-minute break? And when we come back, I think what we're gonna do is, we're gonna talk about, because we've heard all the budget adjustment that we're gonna hear. Kind of talk about how we're gonna put together our, recommendations that we need to send to appropriations. So it'll be just sort of committee work time. All right, so let's go off of